So thanks, I think special thanks to Gerhard. It was really his idea of putting this day together. I'm basically a sort of data geek these days and much happier behind a computer doing some programming than running days like this. But I think this is an important subject, and really it's, I think from an epidemiological viewpoint, you've heard the clinical and the global viewpoint from Dan, some of the research around Group A strep. So this is really about, I'm trying to unpack, how did I become a scabies enthusiast? Why did I get obsessed about scabies? Why do I think it's useful? I think it's useful to also just say that, as Daniel alluded to, scabies is a stigmatising issue, and the intent here is not to stigmatise populations that have scabies, but it's really, this research is done in the spirit of trying to improve things, trying to stop kids getting zips in their chest and dying early from preventable disease. So the talk will be a little bit about why rheumatic fever is important, what's the cause of rheumatic fever, how do I get interested, could scabies be a cause, some recent research, and where to from here. I think this is the thing that motivates me about this area, is that there's important sequelae, and one of my jobs in my junior doctor days was as a cardiology registrar, and we'd have a constant stream of French-speaking patients from Tahiti, young, coming over for surgery, often in dire straits, and often dying young. And so this has been motivating. I haven't really been part of the rheumatic fever research group, so I've kind of come to this as a bit of an accidental tourist, but I think it's allowed me to come in with a fresh pair of eyes and see a different perspective on things. So 12 million a year is spent in this country on rheumatic fever, mainly on heart surgery. How did I get interested in scabies? Middlemore Hospital was overflowing with patients, and I was given the slightly kind of fatigue-inducing job of trying to sort this problem out as an epidemiologist. So I did what I could, and I looked at what was causing the hospital admissions, and it was clear that that in terms of preventable hospital visits, cellulitis was a big issue. Gastroenteritis was sort of top of the pops, and there's major ethnic disparities, and Pacific kids, this is 0 to 4 year olds, were majorly overrepresented compared to other ethnic groups. There's just massive differences. Pacific have high rates of all diseases, but cellulitis was particularly dramatic. There's actually increasing rates of skin infection, and particularly Pacific people were coming in at a much greater rate than other ethnic groups, also mildly affected. So one of the things that got me thinking about scabies was having had the disease myself. I've had it around 7 times, which has been great. I've learned how difficult the diagnosis is. Sometimes me and my wife would sort of go, oh, we're going to have some permethrin again, and I would say, you know, do we have to wait until another case gets it? I think this is more than a mosquito bite. And we'd often have a small domestic argument about this, and sometimes my wife would say, I'm still not sure this is scabies, and I'd say, well, I think this is a permethrin responsive itchy skin disease. Try and sort of ward off the arguments from that point of view. And it seemed natural that reading Dan's work and work in the Pacific, that it was a cause of bacterial skin infection. There's just no question. The other thing that was dramatic was looking at permethrin dispensing in counties and seeing that basically 3% of Māori and Pacific people in the region had been dispensed the treatment sometime in that year. And that was a tenfold difference compared to other ethnic groups. So, and this pricked me up, my ears up, because I knew about the ethnic differences in rheumatic fever incidence, and it's roughly about the same order of magnitude. It's probably slightly higher, about 20, 30-fold difference comparing Māori and Pacific to other ethnic groups. The majority of treatment was with permethrin, very little ivermectin use, most of the treatment going out in most deprived areas of Auckland, lots of repeat prescriptions, so some evidence for me that permethrin treatment wasn't effective, and there was recurrent treatment happening. So what about scabies and rheumatic fever? Well, this is from Frank Netter's textbook. It shows the traditional theory. It's all about strep throat. What do we know about rheumatic fever in this country? It's almost exclusively a disease of Māori and Pacific children. It's linked to streptococcal sore throat infection, clusters in families associated with overcrowding and poverty. Many cases also have bacterial skin infection. Many case reports with bacterial skin infection, Michael's data supporting that now. And the diagnostic criteria based on evidence of strep infection and the clinical features you know about. One of my jobs in public health is to write 3 monthly reports on how many cases of rheumatic fever we're getting in Auckland, and this is seasonal trend decomposition, where you decompose this messy data series into a seasonal component here and a long-term trend of what you're interested in, and you can see that, things are not getting better, things are going in the upwards direction, despite the $70 million program. Where did the evidence for penicillin come from? Mainly from these studies with very small numbers, which were done in the 50s. And the methods are a bit messy if you look at the original papers there. And so they haven't demonstrated a significant result with any except for this one and this one, and I've pulled them, and here we've got the pooled effect. You look at the incidence of rheumatic fever in these studies, and it's enormous compared to what we have now. It's a totally different world in which the time period, the incidence of rheumatic fever in which these studies were carried out. Now, I couldn't hope to do a trial of rheumatic fever prevention with 1,000 patients in each arm. We would need more like 20, 30,000 in each arm. How effective was the throat swabbing? Well, as some people have alluded to, there was a large cluster randomised study done in Auckland, and the results were presented as a positive result, but if you actually look at the statistical details here, you've got a non-significant decline. So the incidence was roughly the same in the two groups. And there's a lot of talk about swab and penicillin failure. I read some of the Aussie stuff that was coming out on rheumatic fever, and there's a paper on chinks in the throat to rheumatic fever theory. Many cases don't have a sore throat. Sore throat's not part of the diagnostic criteria. Some populations have low rates of gas in the throat, but high rates of rheumatic fever. School program based on treating sore throats resulted in no difference. And there's no apparent relationship between gas in the throat and rheumatic fever in terms of the epidemiology. You see high rates of gas carriage in developed countries that have virtually no rheumatic fever. So what about scabies? The traditional theory, as we know, it's all about strep throat. We've shown a cohort study, very strong association between diagnosis in hospital with scabies and the diagnosis of rheumatic fever. And this is really an epidemiologist's dream. We don't see a hazard ratio of 27 every day. In fact, I think even smoking and lung cancer didn't get up to that order of magnitude. Michael's talked about his data showing an association between self-reported scabies and rheumatic fever. What do we know about scabies? I don't really need to go through this because Daniel's covered it so well, but it's a known cause of post-strep GN, cellulitis and abscess. And the Western Pacific is really the highest prevalence region in the world. Given that the data is poor, what we do know, what we have access to, shows that that's the case. It's known to be difficult to diagnose, even for dermatologists. In my discussion with a dermatologist, one of the first things he told me was a dermatologist is not a dermatologist until he's missed scabies. Or she's missed scabies. I don't want to make any assumptions here. And it's almost exclusively treated with permethrin in New Zealand. So I'll just go through a couple of the epidemiological studies that we've been doing. So this is the theory. Scabies leads to strep infection, which then leads to rheumatic fever. And this was the first study. So we took a cohort who were defined by having a dental examination. We had some confounders. This was a record linkage study. We looked at scabies in hospital and scabies in hospital before and after the exam, and then looked at rheumatic fever. And we had over 200,000 kids. And this was the first plot that, for an epidemiologist, is quite exciting. In the group who had scabies, the cumulative incidence of rheumatic fever was 12%. In the group with no scabies, it was virtually zero. In the group with scabies beforehand, it was about 3 or 4%. Here's the regression results. So the crude association has a ratio of 26. The adjusted association has a ratio of 9. And you see that these very strong associations between ethnicity and the disease and the crude association are diminished once scabies is included in the regression, which suggests that part of the association between ethnicity and rheumatic fever is mediated by scabies. So we got that published. It wasn't particularly convincing to a lot of people, pretty convincing to me. So thought, well, let's have a look at the geographic association between prescribing for permethrin and rheumatic fever. And so we looked by census area unit, dispensing of permethrin, and the outcome, the incidence of rheumatic fever in EpiServe, the national collection of notifiable diseases. And the confounders were the proportion of Māori and Pacific and living in each census area unit and socioeconomic status. So again, this is really epidemiologist's dream. I've never seen a map that looks like this. So here, this is a map of Auckland. We're about here. This is South Auckland. Each of these open circles are addresses of cases of rheumatic fever. And the dark shades are where most of the permethrin prescribing is going out. So you see South Auckland is really where and most of the prescriptions are coming out. And there's a very, very strong association between rheumatic fever cases and permethrin. I don't think you ever see something this strong on a map until you look at this. This is the proportion who are Pacific living in a census area unit and the address of rheumatic fever cases, and you see almost exactly the same pattern. So I was a little bit disappointed when I saw that. I thought, how are we going to tease this out? What about the proportion who are Maori? It's not quite as strong. Poverty, socioeconomic deprivation, NZDEP 13, you see a very similar association. So how to make sense of this? I won't show you my clever web app. I'll have to save that for another day. Basically, the collinearity between these variables are highly clustered. So permethrin prescribing in the Pacific proportion in a CAU, I've never seen such a strong association. That's a Pearson correlation coefficient of 0.88. And the other variables here, socioeconomic status, Māori proportion, Pacific proportion, all very highly correlated. So you're really seeing this. I think it must be one of these auto shut-off things. The screen's getting bored. So it's really hard to tease out what's important with a geographic using maps, but you get a strong visual impression that these factors cluster. So going back to our old friend regression that people don't find quite so convincing because it's a black box, we see that permethrin prescribing, if you go from one side of the distribution where there's only 12, the rate is 12 per 100,000 to 147 per 100,000. 323 per 100,000 permethrin prescriptions to just over 1,000, which is roughly the same comparison for a binary variable. You get a 40-fold increase in rheumatic fever. So that's pretty dramatic. That's even more dramatic than the individual patient cohort study. And then once you put in these other factors, it goes down to 16. If you put in Pacific, you get problems with collinearity because there's basically a very strong linear relationship between permethrin prescribing and Pacific proportion. So again, more convincing evidence for me. For those of you who are real data geeks, this is one of visualizing the results. Basically, a regression model is a weighted average of various factors. Here we've got NZDEP, Māori proportion, permethrin. And you can see the contribution of all these factors where we assign them points for each factor in this weighted average. And there's very little variation for NZDEP and Māori proportion. There's huge variation for permethrin proportion. And you can see there's actually a spline term, and we use that to relax the assumption of linearity. So most of the rheumatic fever is occurring in this very high permethrin prescribing group. And all these points, which are basically all the permethrin, they add up to total points. And then once you've got your total points, then they go down to you calculate your incidence of acute rheumatic fever, and that's a log linear scale because we're using Poisson regression. one of the things that's interesting from a statistical or an epidemiological point of view is that actually the relationship between permethrin and rheumatic fever gets penalised in a traditional regression analysis for being strongly associated with Pacific prescribing. But if you actually stop and think, what if scabies were the cause of rheumatic fever? From what we know about scabies, it's very high incidence in the Pacific, we would expect a very strong association with Pacific ethnicity. So it's been very interesting from my point of view, showing that there's limitations to regression modelling when you've got these very highly clustered variables. It's actually very useful to think what would happen, what would we expect if this were the cause. Looking at some of Michael's work, you can see that very strong associations with in the family, poor housing. If scabies were the true cause, would we expect to see strong associations in that direction? I believe we would. So anyway, an alternative method is this Bayesian network learning, where you basically take your hands off and say, computer, tell me what you think are the causal relationships between these variables. And this is what the computer comes up with. The strength of the association, it's all to do with patterns of conditional dependence. And you see very strong associations between all these variables. You see a less strong association between permethrin and rheumatic fever. But you see that these variables are associated with rheumatic fever only because they are associated with permethrin. Some interesting other little tidbits that I've become interested in along the way is looking at some of Dan's and the Australian group's work and at this association between impetigo and scabies. And in Fiji, when they've used different criteria for impetigo, different criteria for scabies, and this is a representation of their results. So basically, if they're seeing impetigo, they're also seeing scabies. And all the published stuff in the New Zealand narrative on impetigo has really been about an antibiotic, a bacterial disease that requires either topical or systemic antibiotics. This was a little study we did with a dermatologist, a GP and a nurse in a childcare centre where there was all sorts of skin problems. And we asked the different clinicians, do you think this child has scabies? This is the total of number that all three clinicians were able to see. It was a bit difficult to get them to see all of them because some were there some days and not others. The nurse thought this group had scabies. The GP thought this group had scabies. Retrospectively applying Dan's Delphi criteria for suspected scabies, this group had scabies. And the dermatologist categorically said none of them had scabies. So it makes a difference what criteria you use to diagnose scabies. So some musings on the results. Adjusting for ethnicity and socioeconomic status reduces the association between permethrin and rheumatic fever, since all these variables are closely related. Since ethnicity and socioeconomic status are strong risk factors for rheumatic fever, if scabies were truly causal, it would be expected that they are closely related to permethrin and permethrin related to rheumatic fever. Permethrin use, I think this is one of the scarier findings or reflections on this for me. Permethrin use, if effective, we would expect it to protect from rheumatic fever if scabies were a true cause. But in actual fact, we're seeing the opposite, that where permethrin is going out, rates of rheumatic fever are highest. And Cello's done a little bit of work, I understand, on permethrin resistance in Australia. And if the same situation is here as in Australia, then that's rather scary. Adjustment for related risk factors shares or dilutes the risk from the causal factor. Traditional regression does not consider likely causal relationships between predictive variables. Bayesian networks provide a more plausible causal representation. Eye-opening trip to Darwin recently, just to see they have an NGO whose mission is to eliminate crusted scabies from remote indigenous communities. A real focus on crusted scabies, and that's an issue that really hasn't been looked at all in New Zealand as far as I know. So again, we're trying to get back to that question that I posed at the start. Is there really a causal relationship between scabies and rheumatic fever? There's all sorts of different ways of thinking about causation in epidemiology, but one of the sort of tried and true criteria is the Bradford Hill criteria, and we've got a very strong association. It's the strongest that I've ever seen, so I think that probably gets ticked off. Dose response, well, we saw some evidence that it wasn't so much dose, but proximity to the diagnosis was more strongly associated than more historic diagnosis. Biological plausibility, I think the Queensland group is really the place to look if you want to look at the biological plausibility. There's a clear path from scabies to strep infection, complement inhibition. Coherence, I think this is probably the one of the strongest features for me, is that wherever you see scabies, you see lots of rheumatic fever. It seems to explain the distribution of rheumatic fever in the world in a way that other things don't. You look at some small print studies where people have looked at echoes for rheumatic fever, and they've correlated that with recent treatment for scabies, both in particularly in Ethiopia, West Indies. There's an interesting description of an outbreak of rheumatic fever that was followed by an outbreak of scabies. All the discussion was on strep, but it clearly states that. Temporality in the cohort study we have. Analogy, well, it's very similar to post-strep GM, which is a known cause of scabies. What's missing, I think, is the experiment. It's very hard to do a trial in this area, and we're thinking about how we might do that. I think another thing, I did my PhD on cardiovascular disease risk prediction and where to put the treatment threshold given a certain level of risk. And there's a whole science around this. And when you're introducing a new treatment, it's usually a consideration of the costs and the benefits. And particularly the benefits to the people who are truly cases and the harms to the non-cases. So at a certain level of risk, which may be defined by a diagnosis or a statistical model, you put a line and you realise, well, we're going to get some benefits from the people who are cases, but we're going to over-treat perhaps, and some of the non-cases are going to get treated as well. And it seems to me that the downsides of over-treating scabies are particularly small, and I think that's why mass drug administration is such a useful approach. And that's what we do for those of us who have cats and listen to our vets. We put some moxidectin on the back of their neck every month, not because we've done an exhaustive search for scabies and or mites and think that they're there, but we know that the treatment, or this preventive treatment, is unlikely to harm the cat and is likely to benefit them. Potential upsides of effectively treating scabies are high. So vets and farmers are ahead of us, I think. Should scabies be a notifiable disease? I'm a public health physician, and it actually is in the Health Act. So I think back in the old days, they realised scabies was a big deal. Somehow we've forgotten it. It's not part of the discussion in public health units at all. And in terms of trying to get it on the Health Act in part one where it actually is a notifiable disease, at the moment it just gives powers to medical officers of health to address it if they think it's a problem. We've got to make a case, does the disease present a material public health risk in New Zealand? Would surveillance and analysis be enhanced? And seeing that it is a notifiable disease, or at least crusted scabies is a notifiable disease in the Northern Territory, I think sets a precedent. Okay, so trying to bring all this together, I hope I've suggested that this provides a fresh approach to rheumatic fever prevention. The $70 million school program has largely been disappointing. I know there's a lot of debate about this, but certainly looking at our numbers in Auckland where most of the cases occur, if this is true, permethrin doesn't look to be effective. I think ivermectin really is an attractive option. And I was heartened, I gave this talk yesterday to public health physicians, and a guy from Pharmac had a talk to me and he said, I've been thinking about ivermectin, we should take it off special authority. Causation is often a neglected issue in epidemiology, but really is the raison d'etre of the epidemiologist, and I think Bayesian networks have been particularly helpful. I think we need to learn from what's happening in Northern Territory and I think about making scabies a notifiable disease. So I'll leave things there. I'm happy to take any questions.
Thank you, Simon. That was really interesting. I'm going to be a little bit provocative here and say that associating permethrin prescriptions with a definite diagnosis of scabies is not really a very accurate way of measuring scabies prevalence. Certainly I see a lot of children with itchy skin conditions who've had a probable scabies diagnosis. I think that's mostly what they're capturing. And they've been treated as a single family member, half-heartedly, and actually don't have scabies at all. They have other itchy skin diseases like eczema, which are more common, as we know, in Pacific Island, Polynesian and Maori populations. And so I think before we jump on the scabies, then maybe we need to be a little bit more clear about what association we're actually measuring.
Oh, sure, yeah. There's obviously some measurement error with that assumption that permethrin is a marker of scabies infestation. And I think, trying to resolve that issue about the diagnosis, I think, is incredibly important. And I guess it's why in the work that I'm planning to do, we're planning to use PCR to get a definitive diagnosis of scabies, and I think that will resolve that issue. But I still think permethrin is, it's the best, without spending a whole lot of resource to look at this issue, it's really been the only way of trying to unpack it. So happy to accept that criticism, but I think it's the best that we've got just at the moment.
So I just want to touch on that point. So when you look at studies from scabies outbreaks to acute rheumatic fever outbreaks, say in the West Indies, is there actually a time period? Like what's the gap between the scabies outbreak and the acute rheumatic fever outbreak? Is there
I can send you the paper if you like.
Yeah.
That whole outbreak, and there was a whole lot of analysis done around that outbreak and post-strep GM rheumatic fever that resulted from that outbreak. They didn't really focus on the scabies. There's a sort of throwaway line in the abstract which says there was an outbreak of rheumatic fever which followed an outbreak of scabies. So the temporality, I can't recall it, maybe in there.
I'm a nurse in a decile 3 school, and probably 80-something% are Pacific. Now we were part of your school programme, rheumatic fever, a couple of years back, and then we've actually continued the programme understanding orders. So should we, with this research, when we get kids in with repeated sores, scabies, we had a bad one about 2 years ago, but we worked very closely with public health, haven't seen much since. Should we be throat swabbing these kids?
Repeated sores and throat swabbing. Look, I'm not part of the school program and I'm not a clinician, so I don't really want to wade into that area. To lead others.
Probably respond to that. I think if you're looking at soft throat swabbing, there's definite guidelines.
That's right. That's what I was asking because we go by the guidelines.
We don't have any links with skin infection and swabbing with soft throat swabbing. In terms of soft throat swabbing, we stick to the guidelines.
But do we need to address that with new research and change the guidelines?
Well, I mean, if I was trying to give advice about the school program, I would definitely look carefully at these new criteria for scabies, because I think in New Zealand generally the clinical criteria that have been applied are generally very, very specific criteria rather than sensitive criteria, and I would be thinking about shifting those towards over-treating scabies rather than under-treating.
Last question. Yeah.
Thank you, Simon, for brilliant presentation. And of course, I was at the meeting yesterday, and you probably heard there were lots of discussion about issues around whakama when talking about Pacific and Maori, especially related to the poor conditions, unhygienic, related to such as scabies and so forth. And there was also a suggestion that whatever we do in this space, we need to bring it out of whakama to whakamana.
Yes, right.
And I think, being a Pacific myself, and actually I used to look after scabies and skin diseases in Tonga. One of the few trained people with skin diseases and infectious disease in general. And it is a great barrier when, even when people are aware or they believe the treatment is good, but they won't show up because everybody will look at them, they say, oh yeah, one of those lazy parents, not. So I hope that part of this conversation is to be mindful of that, bringing out, of course, it's true, where the Pacific and Maori populations are and all the things we have heard. But I'm just hoping that in the process, we would endeavor to make a move from just stating what it is and the obvious, and try to give a sense of empowering and enabling for the people to move away from the whakamā to whakamana.
Absolutely. I mean, I've had scabies several times myself, and you know, I think there's as Dan said from the Twitter stuff, you know, there's obviously this stigma that goes with it, but I think the thing that I'm trying to focus on, I suppose, to address that is to highlight how treatable this condition is and reversible, and that it doesn't have to be something that, you know, to me it's a good news story. It's something that we can actually do something about. So focusing on the reversibility, the treatability of the condition, and the potential to reduce some of these health conditions in the community. To me, that's where the conversation needs to go to try and address those issues. And, you know, and I just say, look, yes, this is a stigmatising disease, but I'm not doing this to try and stigmatise. I'm doing this to try and improve health in these populations.
Okay, I think we'll leave it there. So if you could just join me in taking